Restorative dentistry describes a wide range of procedures your practice may provide for patients to treat damaged teeth and dental decay. It includes everything from simple silver fillings or amalgams, to bleaching teeth for cosmetic reasons, to crown and bridge work. Some offices may only do some or even none of certain procedures. To be the best dental assistant that you can be, you must be knowledgeable in all areas and be able to help the doctor provide them when patients need them. Dental caries and periodontal disease result in the destruction and the loss of teeth and their supporting structures. Dentistry's goal is to comfortably recreate an oral environment for the patient that improves their lifestyle by assuring adequate chewing, smiling, and talking. Restorative dentistry makes up a majority of the treatments provided to patients in the general dental practice. Each restorative procedure consists of many steps, each one being critical to the next. If asked which is the most important, the answer has to be the one you're doing now. The variety of materials used in restorative dentistry is astonishing. Couple that with the different liners and cements placed under the fillings, and it may seem bewildering at times. Thankfully, the basic procedures used are all very similar, and the various materials are fairly simple to learn. So we won't go into too much detail regarding materials, just the procedures. Restorative dentistry is provided for patients in two ways, directly and indirectly. Direct restorations are placed in one visit, directly in the teeth. And some examples are the silver amalgam fillings and light-cured, tooth-colored composite fillings, also sometimes called bonding. Indirect restorations are placed indirectly, meaning with several intermediate stages. Porcelain or gold crowns, inlays, onlays, these are all fabricated indirectly in a laboratory away from the patient. Rarely can they be completed in one visit. Direct and indirect restorative dentistry have some crossovers, though. Heat-cured composites may be made outside of the mouth and later cemented in place, often in one visit, though. And sometimes completely porcelain crowns may be milled in the office in state-of-the-art computerized machinery, and then they can be cemented in the same day. For simplicity's sake, let's consider both silver and tooth-colored fillings as direct examples, and crowns and inlays as examples of indirect restorations. Appearance usually dictates where in the mouth the various materials are used. For example, porcelain crowns and tooth-colored fillings are absolute musts for front restorations. Due to their great strength, silver and gold restorations are great for back teeth. The issue of filling strength is extremely important. Back teeth can exert up to 200 pounds of force, so back fillings must be incredibly strong. Your doctor weighs many factors when helping your patients select the proper restoration that will serve them best. For the most part, your dentist will use his extensive knowledge about dental materials and procedures, along with the patient's preference, in deciding what can work and where in that particular case. Directly placed fillings are classified by types 1 through 6, which are based on the surface of the teeth covered, according to the extent of the disease. It's important for you to become familiar with these, since the filling type determines which materials will ultimately be used in providing that particular treatment. The simplest, a Class 1 filling or a restoration, involves just the chewing or occlusal surface of a back tooth. Amalgam fillings are used most often because of their great strength, although composites are gaining in popularity. In fact, some doctors no longer place amalgam fillings at all. A Class 2 filling covers 2 or more continuous surfaces of a back tooth, one of which is also the occlusal surface. The engineering the doctor places in the tooth is very specific to a Class 2 filling. It's more complex and may require retainer pins and usually the use of a metal matrix band to help hold it all in place as it sets. If a Class II cavity is to be filled with a tooth-colored bonded composite material instead of metal amalgam, the process becomes even more complex due to the demands for dry, clean tooth surfaces. Saliva and debris prevent dependable composite bonds. Class III fillings are one-surface restorations placed in between the front 6 teeth. These are almost always placed using composite materials. A Class IV cavity describes one in a front tooth that has resulted in the loss of a corner of that tooth and also extends into the interproximal space. Again, tooth-colored filling materials are used. The mechanics of keeping a filling of this type in place for the patient calls for unusual tooth preparations and retention materials due to the incredible forces we exert when biting into apples or corn on the cob. When Class IV fillings become too large, there's no other safe alternative but to use a crown to protect the tooth by covering it completely. A Class V filling is one that's placed on the cheek or the tongue side of a tooth, either in front or on a back tooth. Both amalgams and composites are routinely used. The final and the most recent classification is Class VI. This rare cavity is found on the cusp tip of a tooth and usually forms developmentally. In fact, a Class VI defect may need a filling to prevent a cavity from forming in the first place. Here both amalgam and composites work equally well. Indirectly placed restorations include crowns and onlays, which offer full coverage for extremely weakened teeth, and smaller inlays, which are cemented or bonded within a tooth, much like Class II fillings, but with much greater longevity. Full crowns may be made out of gold, which is the most durable and state-of-the-art material, or of a non-precious and cheaper metal. Most front crowns are fabricated using all porcelain, or porcelain fused to a metal base. Onlays that cover only the diseased or damaged portion of a tooth are best made of gold, although porcelain onlays are gaining in popularity. Inlays are fabricated of either gold or porcelain. Gold is still preferred, though, because it's strongest for its thickness, since inlays are usually quite small. Sealants can be our first defense against decay that can ultimately lead to major restorative needs. Encourage patients to seal teeth wherever needed and possible, and you can prevent a lot of possible dentistry having to be done later in their lives. Since the array of materials and instruments needed for restorative dentistry is so vast, let's look at them in use for the different procedures. Your practice may offer patients amalgam fillings. An amalgam is a mixture of mercury, a liquid metal, and various other metals in solid states. Once fully set, the filling is inert and offers a safe and extremely strong replacement for the lost tooth structure. Some practices have moved completely away from using amalgams. If yours has, you may want to fast forward to the next section on composites. As with all dental procedures, treatment can't be provided without the basic setup of a mouth mirror, an explorer, and a periodontal probe, and many setups include cotton pliers as well. Restorative dentistry involves cutting the enamel and the dentin of the teeth with high-speed burrs, creating the potential for heat, which can boil the nerve of the tooth if it becomes too extensive. So water coolants are used to prevent this. High-volume evacuation keeps the treatment field clear for the dentist to see what he's doing. The slow evacuation tip, also called the saliva ejector, removes puddles of fluid without grabbing the soft tissues of the mouth. Rarely is restorative dentistry provided without a local anesthetic. Occasionally a patient might request it and even tolerate treatments without being numb, especially if the decay is small, but it's pretty rare, though, for them to do this. Have a topical anesthetic ready preceding the injection. This offers an extra touch that helps enhance the anesthesia and also the patient's trust. And remember, always keep that anesthetic syringe and the needle out of the patient's sight when you're using it. Cotton rolls and cotton gauze, 2x2s, these help keep the treatment area dry, along with adequate suction, of course. It's best to have on hand as much as you anticipate using, and even a little more, so you don't have to leave the room for more during the patient's procedure. The high-speed dental drill, which is known in dentistry as a handpiece, has reduced the time needed for removing decay and reshaping a tooth from many minutes to just seconds in some instances. Vibration is minimal and patient comfort is enhanced. Notice that the assistant is remembering to use a clean lubricant different from the one used in the sterilization process before it was sterilized. Slow-speed handpieces are used to excavate decay, to smooth, finish, and polish restorations, and to polish teeth. They also have unique inserts that are used during root canals and various other procedures. The different dental burrs, which resemble very small drill bits, help create the desired shape of the space into which the restoration will be placed. All dentists are unique and particular about the burrs they prefer to use. It's a reflection of their training. Burrs that are used in directly placed restorations, amalgams, and composites are usually made of carbide metal or steel. They'll be silver-colored. Diamond rotary instruments, also called burrs, have diamond chips impregnated in their cutting ends. These are extremely efficient, but also generate a great deal of heat. They are most effective in removing rapidly a lot of tooth structure, especially during indirect restorative dentistry like the fabrication of crowns. In general, large shanked number 4, 6, or 8 round burrs are used to excavate decay. The number 2 round burrs are used to create retention slots for fillings and are sometimes used to open pulp chambers during root canal therapies. Straight burrs, like the number 57 shown on the left here, create parallel walls and rapidly remove dental structures. Number 557 burrs are similar, but have slightly larger and more cutting edges. Shown on the left here are tapered burrs. These leave diverging walls that have proper tapers for setting indirect restorations into place. The inverted burrs on the right create converging walls. These help lock the amalgam fillings into place. Fine-bladed finishing burrs of many shapes and sizes create surfaces that are free of scratches. Costing a good deal more than disposable burrs, they require extra care in cleaning and sterilization. These burrs usually have gold shanks. As a rule, the higher the burr number within a group, the larger the cutting end. For example, the number 8 slow-speed round burr shown here is larger than a number 4, and so on. The burr block holds the various burrs. It's often also their container used during sterilization. All reusable burrs, usually diamonds and finishing burrs, must be sterilized between patients. One-use disposable burrs are preferred and should be used when possible. Be sure to discard them in a red sharps container after use.